So I think we'll start now because it is 7 o'clock on the dot. Hello, everyone. Thank you very, very much for joining. Lovely that you're there. And we're absolutely delighted to have Professor Katharina Pachmann with us again this evening. Some of you may know her from the past. She's given many webinars for us and also come over to England to conferences that we've had on this topic. She's going to speak for about 40 minutes this evening on this topic, prostate cancer and testing for it. And then we'll have ample time for questions. Please pop them in the chat or the Q&A. So just to introduce her briefly, Professor Pachmann runs the Maintrac laboratory in Bayreuth, Germany, together with Dr. Ulrich Pachmann and a team of 45 staff. She's both a medical doctor and a research scientist and has been conducting studies in this field and refining related techniques for over 2 decades. She, together with her teams, has authored over 100 peer-reviewed scientific publications on the technique, and she travels all over the world to present on these types of tests. She was at the American Association of Cancer Research in Chicago just recently, and will be going next week to the San Antonio Breast Cancer Convention, where they always either present or certainly have posters on their latest studies. So over to you, Professor Pachmann. Thank you so much again for being here. And I'll switch off my video over to you. Thank you.
Thank you, Gillian, for introducing me. Well, I will start immediately, and I will tell today about the circulating epithelial tumor cells and circulating cancer stem cells in prostate cancer and the evaluation of the clinical potential of these cells. So prostate cancer worldwide have been new cases in 2022, more than 1.5 million cases, and about 500,000 deaths. So the survival is better if the cancer is diagnosed at an early stage, localized or regional, and the 5-year relative survival exceeds 99 to 100%. But if the cancer is in an advanced stage, metastatic or distant, then the survival rate drops. And risk factors are age, family, history, ethnicity, diet and lifestyle, and hormonal factors and chronic inflammation. So the diagnosis of a tumor is a devastating event. The Latin word tumor means just only swelling, but in more specific medical sense, a tumor is defined as a benign or a malignant new growth of body tissue arising from a dysregulation of cell growth. And imaging techniques can detect tumors from about 0.5 centimeters in size. The structure of the tumor can provide clues about whether it's benign or malignant, but the definitive diagnosis is only given by the pathologist by a biopsy. And it's assumed that every cancer begins with a single tumor cells that multiplies through cell division. And after 10 doublings, it's about 1,000 cells. After 20 doublings, it's about 1 million cells. And after 30 doublings, it's about 1 billion cells. And that's a tumor of 1 centimeter. And then it is detectable. The tumor requires blood supply for further growth at the size of 1 millimeter. That's 1 million cells. And the nutrition reaches the tumor through the blood. But cells can also leave the tumor at that time. And these tumor cells are then in the blood and circulating and can remain in the bloodstream for a long time and spread throughout the body. These cells can then exit the bloodstream at other sites and form metastases. And that is shown here. So the tumor gets blood supply, and blood cells, but also tumor cells can circulate, then get into the blood and circulate. And if it is a cell that is active and exits from the tumor, as you can see here, then it can divide and form a metastasis, and even cells can differentiate and in the growing tumor, and even cells from the blood, more differentiated cells, can enter the metastasis and increase the size of the metastasis. So these cell division in the tumor and in the metastasis can occur rapidly or slowly. Rapid growth would be, for example, doubling of cell numbers in 1 month, and slow growth, doubling in 6 months. This is just a model. And as I said, a tumor of 1 centimeter is then detectable, and that's 1 billion cells. So if the tumor is starting from 1 malignant cells, it can be detected after approximately 25 doublings. And if it's a fast-growing tumor with a doubling time of about 1 month, it will take about 2.5 years until the tumor becomes detectable. So if a patient undergoes annual PSA testing, there will be no PSA increase detectable, and the tumor is not detected. But only a few months after the last examination, a tumor can become clinical apparent, and this would be considered an interval tumor. And if cells have already been shed and settled and grow at the similar rate as the primary tumor, metastases may appear in about 2 to 3 years after the initial diagnosis of the primary tumor. And this is shown here. So if the cells in the blue line or the blue dots grow and grow, and if then the onset of the blood supply starts and cells are shed and they grow at the same rate, then they will not be visible yet after 48 months, but soon after they become visible on CT. If it's a slow-growing tumor with a doubling time of around 6 months, it takes about 12 years or more until the prostate tumor becomes detectable. And if a patient undergoes annual PSA testing and imaging, the tumor is detected during routine diagnostics. And if tumor cells have already been shed, settled, and grow at a rate comparable to the primary tumor, metastasis may remain undetectable even 10 years after the initial diagnosis of the tumor. So from the tumor size, it's not possible to determine how long the tumor has been growing and if and when it will form metastasis. And that's shown here, the slow-growing tumor, the blue line, the blue dots. And if cells have been shed at 10 years and the tumor becomes only detectable at 13 years, metastasis will not be detectable, maybe even during the whole lifetime of the patient. So it's very important whether the tumor is growing fast or slowly, and the prostate cancers are mostly growing very slowly. Therefore, it is important to have a procedure that allows detection if there are living tumor cells in the blood. And this is performed with our Maintrac analysis. What can we do? We can count the cells and see whether they increase in numbers. We can test on these cells whether therapeutic substances are active and can destroy the cells. We can test whether these cells have therapy-relevant characteristics would help to fight the tumor. And last not least, we can also look for tumor spheres, that's stem cells among the tumor cells, which show whether the tumor is very active in growing. How can we detect these cells? Tumor cells from epithelial tumors, like the prostate cancer, have on their surface molecules which are not detected in blood cells. So they distinguish, these molecules distinguish the epithelial cells, like prostate cancer cells, from the blood cells. And we have an antibody against such molecules, especially the so-called EpCAM antigen. We can stain the cells and then we can detect them. This can be used for all solid tumors of epithelial origin. It's highly sensitive. We do not enrich the cells. It's fast, and we have shown that it's reproducible, and it's performed in a certified laboratory. How do we proceed? If you send us the blood sample, we just lyse the red blood cells because they are 1,000-fold more than the white blood cells, and then spin down the white blood cells, stain them, and the tumor cells among the white blood cells will stain with the anti-EpCAM antibody. We transfer it to a 96 well plate and have a special microscope going over the wells, and then it can tell us where there are the tumor cells located. We can relocate them, and we can distinguish whether they are living cells or dead cells. And that's shown here. So on the right panel, that's the living cells, which, as you can see, among all the background of unstained cells, and they have a nice nucleus. In the middle panel, that's questionable cells, which are not nicely stained, which we omit to. And on the left panel, that's the cells in the process of dying. And if they are in the process of dying, the membrane of the cells becomes permeable, and a red fluorescing dye can enter the nucleus and tells us these cells are in the process of dying. So we give you the numbers of the cells detected in this panel here, and with estimation how high these numbers are in the context of other cells. We can monitor these cells during or after therapy. So it makes it possible to adjust the therapy and directly determine the tumor activity. And it's thus an additional tool to optimize and modify therapy. This here is the case of one patient where you can see we have been monitoring the numbers of cells over time. He had been diagnosed in 2018, had surgery, and it was a low Gleason prostate cancer. But in September 2019, he had a relapse, and this was treated with radiotherapy. And after radiotherapy, cell numbers dropped nicely and remained low during the whole time of therapy, which was GnRH analog, depressing the production of hormone, and in addition with naturopathic treatment. And cell numbers have been remained stable and low, and this is consistent with clinical remission. This is another patient who had been treated after the relapse in 2010 and an additional relapse in October, biochemical relapse, and had been treated with bicalutamide, where the level of circulating tumor cells remained stably low. And this was a clinical remission. But then, because all treatments for prostate cancer will decrease lifestyle, he stopped this treatment. And then we saw a massive increase of circulating cells together with the relapse. So it would have been maybe better if he had, during these 3 years, had previous analysis which might have shown the increase in tumor cells earlier than the relapse. In addition to just monitoring, we can also test the sensitivity of the cells to different conventional and naturopathic treatments. We can thus demonstrate whether the cells are sensitive or insensitive, non-responsive to the plant cytotoxic substances, and the substances can also be tested in various concentrations and combinations, and also under hyperthermia. So when should we test such drugs? It is, for example, after the initial diagnosis of the primary tumor before therapy is initiated, or in a metastatic setting, starting a new line of therapy, or in cases of disease progression during ongoing treatment. And we then report the results in this in our report and give it as a percentage of dying cells in response to the respective substances. Here, docetaxel, which is usually used in prostate cancer, is the most effective one. And if it's over 50%, then it can reflects also the response in imaging scans. We can test different naturopathic agents, but we can also test those which are not given in this panel, and you can tell us which substances you want to be tested. And we can also test combinations of substances. And this for example, are natural agents, and you can see that artesunate, for example, is very active, and in this case, for example, curcumin was not as effective. So we can test different substances, and we can also compare them to conventional substances as shown. For example, this is not in prostate cancer, it's in another cancer, but you can see that in this case, curcumin was much more effective than, for example, cisplatin in this patient. I told you that we can also test combinations of substances. Here, for example, it was curcumin together with hypericin, which was very effective. And we can also test different concentrations from the one which is supposed to be given, the one-fold, 0.1-fold, so 10-fold lower and 10-fold higher. And from this you can determine which concentration would be perhaps optimal for your patient. And this is just a patient shown. And here you can see that docetaxel was really in this prostate cancer the most effective one, but curcumin and artesunate were as effective. And during the treatment in this 55-year-old man, we could monitor the effectiveness, and the cell numbers remained low the whole time. So in this patient, the individualized complementary therapy in combination with testosterone deprivation therapy resulted in a good reduction consistent with clinical remission. We can also test the cells for therapy-relevant tumor cell characteristics, because some therapies may only make sense if the tumor cells have the corresponding characteristics. And this can tell us whether a certain therapy will have a high probability to be active. The tumor characteristics can also change during the course of disease, and this can also influence the effectiveness of the therapy used. And here, this is just an example. In prostate cancer, mainly markers like PSA, PSMA, and androgen receptor are important. This is shown here. We can test the cells together with the EpCAM for these markers. PSA is a marker that is usually looked at in serum, but it's also expressed on the cells, and it tells us that these cells belong to the prostate. And we can see what frequency of cells is belonging to the prostate, or is sure it belongs to the prostate. PSMA is a marker which is used for CT testing, the PSMA testing, because an antibody against the prostate surface marker antigen can be used in an radioactively labeled form to detect tumor cells, for example, in lymph nodes or in other organs. So it helps to tell whether PSMA CT will be helpful. And there's even a PSMA antibody, which is highly conjugated with radioactivity, which can also be used for treatment then of these patients. And again, the PSMA expression on the cells tells us whether such a treatment will be helpful. The androgen receptor on the cells is mostly used to answer the question whether anti-hormone treatment will be helpful, because if it's overexpressed on the cells, they will be responsive to the anti-hormone treatment. I here mentioned also immunomodulatory molecules. That is the death receptor ligand, which is expressed on the tumor cells and which stops the immune T cells from aggressing the tumor cells. So it's a break between the T cells and the tumor cells, and this can be lifted by so-called immunomodulatory antibodies. So this is not very frequently used yet in prostate cancer because they often are slow-growing cancers. And this is also shown with the proliferation marker, where the Ki67 tells us whether these cells are in the cell cycle and are growing rapidly. This is an example where such markers were monitored on the cells, and you can see that in this patient, which suffered from a lymph node metastasis in 21, before this lymph node metastasis, there was an increase of androgen receptor, PSMA, and PSA. So most of the cells in the blood were from the prostate, and they were active. And then the lymph nodes were removed. Cell number, the expression of these receptors did decrease, but it re-increased during a renewed treatment with leuprolide, and this was detected before the relapse in the retroperitoneal lymph nodes. Now I would like to come to the Stemtrac, which is a method to assess tumor aggressiveness and risk of metastasis. The cancer stem cells are a distinct population within a tumor and within the circulating tumor cells. These cells can self-renew and also differentiate into more differentiated cells. It's assumed that these cells that are responsible for tumor initiation and for tumor recurrence and metastasis. And they are often resistant to the chemo and radiotherapy, and therefore current treatments may be ineffective. Strategies to eradicate these cancer stem cells are in the focus of cancer research, and therefore it's important to know whether there are such stem cells among the circulating tumor cells. How do we proceed? Again, if you send us the samples, then we lyse the red blood cells. We have the white blood cells in the sediment, and these we seed into cell culture flasks. And then we add a medium which preferentially makes the cancer stem cells grow, and they grow into small spheres. We call them tumor spheres. And then we can detect these tumor spheres and can also calculate the number and whether the numbers increase or remain stable. And that's how these spheres look like in reality. And then we can test additional markers on these cells, which are typical for cancer stem cells. And we can count them again under the fluorescence microscope. We have published this approach in 2016, and this allows assessment of the risk of metastasis formation and monitoring whether the therapy can eliminate these cells, and it's also helpful for detection of a possible relapse, early detection. And this is again this patient I showed before, but now it's the circulating cancer stem cells. And it shows that after radiotherapy, also the cancer stem cells did nicely decrease and remained low. And this was consistent with treatment response and clinical remission. The other patient, which I also had shown before, and now again, it's the cancer stem cells, which remained low during the bicalutamide treatment. But after stopping, the number of cancer stem cells did increase to 400 per ml, which is consistent with the newly diagnosed liver metastasis. So again, here the increase in cells was due mainly to the cancer stem cells. And this is another patient where there was a stepwise increase in these cancer stem cells. The relapse, the patient had a relapse in 2017, and we tested him again only after the relapse in 2019. And you can see there's always, in spite of the treatment, an increase in cancer stem cells, which finally increased to a high level. And this preceded, in this case, the metastases, which were diagnosed 3 months later. So now I'd like also to tell about one publication which we have published this year, which may help to advance our understanding of tumor growth. And this was the analysis of the circulating tumor cells during radiotherapy. Radiotherapy is a preferred treatment of prostate cancer, and it can be done without surgery, which has quite a lot of side effects. It can be done only without any surgery, and it can be done after the PSA has been increasing after surgery. But there is no reliable biomarker to predict whether this radiotherapy is working. And we have evaluated whether the circulating tumor cells can serve as such a biomarker. We did this in 52 prostate cancer patients, and the blood samples were collected before, during, and after radiotherapy and measured. And those patients in the green or line, which had decreasing cell numbers, we could detect cells in all patients, almost all patients, but those with decreasing cell numbers during radiotherapy have remained relapse-free even at 8 years, most of them at 8 years, whereas those with increasing cell numbers, and that's the purple line with this is a Kaplan-Meier plot where it shows relapse, every tick down is a relapse, and there was a much higher number and a higher frequency of relapses if we could detect an increase in cell numbers during radiotherapy. So the hazard ratio of relapse was 8-fold higher in the patients with increasing cell numbers than with stable or decreasing cell numbers. And this means that we can show already during this treatment that some of the patients would need more treatment after radiotherapy. This was not reflected by the PSA levels, which also were measured during this time. So if patients who prefer not to have surgery, or that's the definitive radiotherapy, or even after adjuvant, that means previous surgery, we can show that these patients, if they have increasing cell numbers, need more treatment, but if they have decreasing cell numbers, there is very little risk of recurrence. This means monitoring of the circulating tumor cells during radiotherapy can provide valuable information about progress and may identify patients at a higher risk of recurrence, which much more effectively than PSA. So I think I came to the point, to the end of the presentation, and you are welcome to ask questions.
Thank you very, very much. That was really very clear and interesting. I don't know if you want to stop sharing, perhaps, Professor Pachmann?
How?
Then we will be able to see you and your face. It will be larger.
Okay.
That's great. Thank you.
Okay.
So I'll just have a look at the Q&A to start with. Mira says, that was a mind-blowing webinar. Thank you very much. How can one living in the UK be tested by this method? And are there any doctors who cooperate with you? Mira, we can mention that the Academy of Nutritional Medicine holding this webinar does represent Maintrac in the UK. So please do, by all means, just contact info@aunm.org. And Hayley, perhaps you could put that contact into the chat. Thank you. Yes, we do have doctors who cooperate with us. If you wish to test for chemotherapeutic agents, then it is essential that a medical doctor does accompany you during that process. And perhaps Hayley, pop in my details as well, just Gillian@aunm.org. We're happy to make contact between you and Professor Pachmann before you do the test as well, just to ask what type of test would be advisable sometimes if it's an advanced cancer, unfortunately, it is more advisable to go straight to the Stemtrac test, isn't it, Professor
Well,
Pachmann? So there are, interesting sort of tweaks in what
yeah,
one can actually do here. Go ahead. Sorry.
there's often the question whether we should do the Maintrac on the Stemtrac immediately.
Mhm.
Well, it takes more time to answer the question whether there are stem cells present because we have to grow them for 3 weeks. So if you do the Maintrac, you can already see whether there are cells present. But if there is an increase in or progress in the tumor, then it might be advisable to do the Stemtrac immediately. And then we can also, which I did not show, but we can also test different substances on the stem cells directly. The problem is that the stem cells have been grown in vitro, whereas the Maintrac cells are directly from the blood, which the growth may change the properties of these cells.
But
But
you do, go ahead, sorry.
no, thank you.
I was just going to say, you do notice that it's different substances that work well in terms of creating apoptosis on the metastasized cells very often rather than the cells in the circulating tumor cell test. It does change, doesn't it?
The stem cells which we grow are often more resistant to substances than the
Sadly.
Single circulating metastatic cells.
Yes. So as I mentioned, we are very, very happy to put you in contact with Professor Pachmann to have a discussion even before you do the test, if you wish to. And yes, we are going to make the webinar available for replay. So that's on the website www.aunm.org, and then you'll see Maintrac in the bar at the top, and it's under webinars. We've done several with Professor Pachmann in the past, as well as with other doctors. So Katharina is asking, that's Dr. Grubok is asking, could you do a Maintrac and then decide to carry on to do a Stemtrac on the same sample if indicated?
Yes, that's possible. We report the results immediately if you want to. Next day after the sample has arrived at our place, and then we can decide whether we would do a Stemtrac test.
Yeah. So
That's
it would just be a
still,
good idea.
yeah.
It's a good idea to write on the form or to tell our helpline when you're ordering the test that
That you would,
instruction needs to be put on there, that the the results are reported immediately so that decision can be made.
yeah.
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 I'll just go to the chat because I haven't yet looked at that. Sorry. Yes. How do you decide whether to do a Maintrac or a Stemtrac test?
Yeah, that's we would prefer or suggest you take first the Maintrac because then you can see whether there are cells present. But in some cases, in advanced cancers, there can be a de-differentiation. That means the cells do not express the EpCAM anymore, but they still grow in the Stemtrac test. And then we would suggest, if it's a advanced cancer, which is still has signs of growing, to do the Stemtrac tests immediately for the patients. But as I said, it takes longer time until we get the results. And the cells are often less sensitive to different substances.
Yes. Another question here is how much Stemtrac is compared to Maintrac. It is more expensive.
Yes.
It's about twice as expensive, but do ask our helpline what the costs are because
Yeah.
they have the exact prices.
That's because we have to grow the cells, and it is more cumbersome than just detecting the cell.
Absolutely. Yes, yes. There's a lot of manual work involved, isn't there? Another question here is, how effective is this method for screening? Is it actually permitted to use it for screening?
Well,
Or you know that the patient
we
has
have
cancer?
not much experience yet in screening. Uh, we had two patients now where there was a screening with the Stemtrac, and she had high numbers. And indeed, shortly after the tumor was detected, this was a breast cancer patient. It may not be as helpful in prostate, which is a slow-growing tumor. But yes, we have no still statistics about that.
Yeah, I think your advice is generally not to use it for screening, isn't it?
No,
But only to
no,
use it if there is a suspicion that, if cancer has been detected,
that's
then
exactly.
for
Yeah,
monitoring and or for
yeah,
testing the substances, whether natural or pharmaceutical.
yeah.
Is there benefit to using Maintrac as part of an active surveillance program?
Yeah, that's the often asked question. And we will publish one paper in the near future where we showed for prostate cancer patients whether screening is helpful. And indeed, in patients over 50 up to 70 years, we did screening in a small group of patients, but it was very clear and very convincing that patients with increasing cell numbers, circulating epithelial cell numbers, had very shortly after the diagnosis of a prostate cancer, though still at a low Gleason with where the question is whether it needs to be treated. But yes, we could find this early.
There was a correlation. Yes,
There was a clear, it was more than tenfold higher in patients with increasing cell numbers, and this might also help to calm down patients when they have low or decreasing cell numbers over the time of testing.
Mhm, mhm. One question that came up from your presentation is, how soon after radiotherapy, if radiation therapy, if it's been discontinued, would you recommend testing? In other words, how long should the patient wait?
After the radiotherapy,
Yes.
well, we would even suggest we test it during radiotherapy at the beginning, middle, and end, and then see how resistant cells develop or not, or cell numbers remain low. And then every 3 months after the end of radiotherapy.
Okay. In a patient where they had radical radiotherapy completed and LHRHA from March 2025 and completed the third injection in September, their oncologist told them they were happy to discontinue ADT, and the PSA is now 0.28. Is it worth considering Maintrac following this
It
therapy?
is indeed worth considering because the PSA can increase in because cells have been killed during the radiotherapy, and it's known that the PSA can remain elevated for a long time, so it does not really tell whether the cells are still present or not. It's increased for a long time, so it's not really helpful during this time.
That was particularly impressive in your study, that you showed that
Yeah,
there was no correlation with the PSA.
no, there is no correlation.
Yep. So would you suggest in that particular case that we've just outlined testing once every 6 months or so? Or do you
Yeah,
think that,
yeah.
yeah?
Mhm. Can be more frequently, but at least every 6 months. Yeah.
Okay. Yep. And then another doctor here is asking, how do you test the natural substances and herbs? Does one supply one's own? She goes on to say, my line of thinking is that different brands have different strengths of, for example, turmeric, or doesn't it matter?
No, we can test any substances if we have them not available at our lab. We would need you to send a sample and tell what concentration you consider, and then we can test tenfold and a tenth of the substances and make a curve where you can then determine what concentration you would best take.
Yeah, some therapists have their own preferred approaches
Sure.
to particular tumors, and they would ideally send those in, as you say, if you don't have
Sure.
them. Please just ask us if you don't know whether the lab has that particular either chemotherapy or natural agent available, and then sending it in together with the sample is something that we would just, highlight to the lab, and then they can obviously use that as well. Um, one, in our conversation previous to the webinar, Professor Pachmann, you mentioned PSMA PET scans as a good way of testing patients clinically before they go ahead with a test like this. And I don't think that that's something used so commonly here in the UK. Can you just explain to us what the benefits of doing a PSMA PET scan are, in addition, of course, to doing a
Well, it's
PSA?
now acknowledged, at least in Germany, and like, for example, Australia, where we did the tests, it's acknowledged as analysis, which tells us whether there are tumor cells present in the prostate or even in other organs distributed in the body. So PSMA PET, that's a test where the PSMA antibody is conjugated with a radioactive substance, and then you can really see whether such cells are present somewhere in the body or in the prostate. And this is acknowledged as a test for tumor.
Yeah, the M stands for membrane, doesn't it? How
Yeah,
does that distinguish itself from the PSA?
PSA, yes. Mhm.
But when you use the term membrane, is it looking for the adherence of these cells to other parts of the body and not just the prostate?
No, that's just the name of this um, PET CT because it's an antibody against prostate membrane antigen.
I see, thank you. And with the posters that you're going to be presenting next week, could you just give us a few advanced details of those? It's always
Yeah.
fascinating new research that your lab is doing, I know.
So this is mainly or only about breast cancer because it's the San Antonio breast cancer meeting. And there we show that we can even these tumor stem cells, which I mentioned, can grow them on egg membranes of uh, well, embryo, egg embryo, and
Okay.
then there because there are lots of growth factors in these membranes. There are really small tumors growing, and we can test then these tumors for their uh, relationship to the original tumor, and we have shown that it's tumor of the same properties growing on this egg membrane as the original tumor. So these stem cells are in fact derived from the primary tumor and have the same characteristics then growing on the membrane.
That's real evidence that they are stem cells. That's quite stunning.
And in the future, we can then also test other substances like those which are necessary for vascularization, which we can't with our current tests yet. So we can test whether certain substances can stop the vascularization of the tumor and thus stop growth of the tumor.
Tremendous that you're constantly doing research of that kind as well. Thank you. A question came in about that PSMA PET scan that you mentioned just earlier. How big would the tumor have to be detected by the PET scan? Would it miss it if there were only small ones?
Sorry, this I can't answer directly. I would need to look it up what size of the tumor can be detected. But it was all the tumors were low Gleason. So it was early tumors which were detected by the PSMA PET.
Okay, thank you. And have you seen, or has the lab seen an increase in this kind of tumor?
Yes.
Over the last 5 years? I know we've seen a particularly difficult time.
Yeah. Also the prostate tumors have increased in numbers, and currently almost every patient who is more than 80 years old after he's died, a prostate cancer has been detected, so it did not impair the patient's life quality yet.
Okay, gosh. And would you say that watch and wait is to be recommended over surgery in most cases, or are there particular sort of parameters that one needs to apply, the criteria?
It's very much up to the patient, because surgery will have heavy side effects, impairing the quality of life of patients. And there has been investigations showing that the patients with watch and wait have more metastasis, but they live the same time of life. So there is no change in overall survival. It is more metastasis, but if the metastases are small and don't impair the life quality, then it's okay, obviously. It does not, neither surgery nor radiation do increase the length of life after the
diagnosis?
Yeah, exactly.
Fascinating, thank you. One listener is saying that his impression is that active surveillance is more common with younger patients and watch and wait with older, late-stage patients. Is that true from your point of view in general?
No, I don't have the impression, but for younger patients, the influence of surgery is much more devastating than for older patients. So I can well understand that younger patients prefer to watch and wait, because so far, as I said, lifetime experience is not changed by the intervention.
Because this is such an important topic and unfortunately increasing, it might be nice next year to have a round table together with Dr. Flora, who, of course, has so many decades of experience treating patients as well as doing this test. from Australia, if we can find a time that is suitable for him, together
Yeah,
with you
it's not
and
so easy.
with another doctor or therapist, perhaps
Yeah,
from here in the UK,
yeah,
to talk about approaches to
yeah,
supporting patients with these diagnoses. So that would be a fantastic outlook, perhaps, for
yeah,
next year.
yeah.
Thank you so much. It's been a wonderful session. I think we've all learned a lot. Oh, can I just ask? I noticed with one patient where we had this horrible upward trajectory,
Mhm.
that it was just resveratrol that he had been using. You had resveratrol at the
Yeah,
top there.
yeah, yeah.
Um, is that a case where, again, if the patient had perhaps tested earlier, one could have said, look, wonderful as resveratrol is, it doesn't appear to be working in this particular case. Let's
Exactly.
just switch the therapy. Uh,
Exactly. I would have recommended this. Yes.
okay.
Yes.
Yeah. No, it's a message, I think, to everybody listening and to anybody who watches the recording. Please do give as much detail as you can to the lab about the therapy that the patient is currently on, if they are already pursuing therapy, because the lab will then add that to their trajectory that they produce for you if they do 2 or more tests.
This
And
would
that
be
is quite
wonderful.
helpful because many
Yeah.
years later, or if there's a switch in therapists or whatever, one doesn't always know that. And
Yeah.
it really helps to see what's worked and what hasn't
This
worked.
is very, very helpful.
Mm. Okay. Well, thank you so much. That was really tremendous. And thank you, everybody, for being there. Wishing you a very happy Christmas, Professor Pachmann, even though I know it's a few weeks
Same
away,
to
but
all of you. Yes.
it's going to reach us far sooner than we realize. And we will be having lots of fascinating webinars in the next year. The next one is at least the next planned one. We can always have, others popping up in between. But the next one that's definitely planned is on the 13th of January, when we will have the head of the Cell Trend Laboratory explaining the origin of their tests, the background to them, and the meaning of those antibodies. So that's a fascinating test as well that has evolved in Germany. You'll know, I think, Professor Scheibenborgen and Professor Wirth and the others who've developed these tests, or at least
Okay.
certainly
Yeah.
helped
Yeah.
to. So we'd love to have you, perhaps if you have time, watching that with us as well, Professor Pachmann, because you've talked so much
I
about
will.
antibodies today.
Thank
Thank
you
you,
very
everybody,
much,
for being there,
Tilly.
and
Thank you.
again
And
soon.
happy Christmas to everybody.
Thank you.
Bye.
Bye bye.